All right, hey guys, we're gonna do a quick video, one of these ones me driving to work. I want to do a quick video on some of the complications that you can have in a delivery. So we've already done an obstetrical assessment video, and I've already done like a normal delivery video, what you should expect. Now let's talk about the complicated delivery. So again, baby is out. We've had mom is in labor, baby's crowning, and we'll kind of talk through some of the complications that you can run into. The first one, let's start with mom, would be after baby comes out, do we have some postpartum hemorrhaging? So it can be from a bunch of different things. It could be tears in the birth canal, it could be abrupto placenta, or a part of the placenta is bleeding. The uterus can be torn. Lots of different things can happen here. It'll present with like uncontrollable amounts of blood, typically. So if you go back to our trauma treatments, we would apply direct pressure, maybe even consider wound packing. In a delivery in this setting, none of those really work. There's nothing we can apply direct pressure to, and we can't wound pack in a cavity like that. So all we're gonna do is take abdominal pads and try and just stop the flow of blood as best we can. Just hold abdominal pads there. It's not really gonna help a whole bunch. What we wanna do is find a way to get the uterus to contract itself. So there's a couple things we can do. First of all, we'll give oxytocin, 10 units IM, and that'll help cause that uterine to contract on its own. That's actually why skin-to-skin contact right after birth is so important, because it releases oxytocin from mom. The second thing we can do is consider a dose of TXA. So a gram of TXA in a bag over 10 minutes, and that'll help with the bleeding. The other thing we can do is a fundal massage. So putting your hand right up at the fundus. Some people use a fist, some people use like a blade hand, and you're going to push down pretty hard and kind of rub that fundus to try and make it contract. Now, when you push down, if the fundus is not contracting, it'll feel soft, kind of squishy. The word that you'll hear in a lot of like practitioners use is a boggy fundus. It feels boggy, as opposed to a firm one that's contracting. If it feels firm, a fundal massage probably isn't going to help. If it feels soft and squishy and boggy, then a fundal massage will definitely help. If you're unsure, just do the fundal massage. It won't hurt. It's uncomfortable for the patient. And otherwise, transport. Our next complications with delivery, I'm going to do two of the more serious ones first, because from our perspective, there's not a lot we can do. So that's a prolapsed cord or a single limb presentation. A prolapsed cord would be the cord comes out before the baby, and a single limb would be like an arm or a foot sticks out. And again, single limb. So the problem with single limb is that the other limbs are kind of getting stuck in the pelvis, and the baby can't be delivered. And then the prolapsed cord, the problem is as they deliver, the baby's going to squeeze the cord and could end up cutting off their own oxygen supply or choking themselves. So in both cases, we're going to elevate the part and keep it covered. So if it's a prolapsed cord, we'll use relatively moist dressings. We don't want it to dry out. And wrap it in something that's going to keep it warm. So a plastic bag to keep the heat in, probably dry warm blankets over top, but something wet right on the cord itself. We can then tell mom not to push. So there's an old flight medic joke I heard. Calls like this require 2 aspirin. One for mom to hold between her knees so she can't push, and the other one for you because this is a really stressful moment. So that's prolapsed cord. Limb presentation, same thing. We're going to cover it. We don't need to keep it wet so much, but we really need to keep it warm. Newborns don't do well with hypothermia, so we have to keep them nice and warm. And then again, tell mom to stop pushing, breathe through her contractions, drive really fast. Both of these presentations require expert intervention. It might be a C-section or some maneuvers that we just don't have. Okay, next two issues that we can run into. One of them would be cars in front of me. One of them would be a breech delivery. So this is when baby comes out 2 feet first or butt first. Again, doesn't happen often, especially with good prenatal care. We can kind of keep track of where baby's lying and positioning, and medical interventions can be done before to keep baby in the right spot, but it does happen. So breech delivery, we see 2 feet coming out. We're going to put mom in the Mick Roberts position, so that's knees to shoulders, and we're just going to help her push, tell her to push. As the baby comes out, we can elevate. When it gets close to the head, you can drop the baby's head down a little bit, or the body down, but you want to support it as best you can. Try not to like overflex the neck. If labor stalls for any reason, you can put your hands inside and do like a V shape like the Spock sign, to lift the tissue up off baby's mouth, and you're going to have to transport like that. Again, this is baby stuck in the breech position. We don't want their airway occluded for that long, so that's how we'll manage that. So McRoberts, God delivery. If both legs are up over their shoulder, so there's the butt sticking out, we can put our hand in and do try and do a leg sweep to try and sweep the legs out. Again, McRoberts position first, try and sweep the legs. If you can't, you're going to put your hands in, try and keep the tissue off the airway if you can, and stop delivery, drive really fast. Breech historically was delivered pre-hospitally. Nowadays, breech is always done by cesarean, so it's always a C-section. So it's a really dangerous situation to be in, and it's higher likelihood of postpartum hemorrhaging. Last situation that second and last situation we're worried about would be shoulder dystocia. So this is when the shoulder gets caught up in the top of the pelvis. So baby's coming down the birth canal, all is good, shoulder gets stuck. What we're going to do is we're going to use what's called the helper mnemonic. Now the helper mnemonic is written for residents and obstetricians. So some of the parts aren't really relevant to us, but a lot of them are, and it's a great way to remember what to do. So H in helper stands for call for help. Hopefully at this point you've got backup on the way. Maybe you've even been on the phone to the obstetrical team, and you've got them kind of ready to go. But hopefully you've got backup on the way, or they're on scene already. Next, you're going to elevate the legs. So that's going to be that McRoberts position, knees to shoulders. So really flex, mom. Then we're going to go to L, which is, oh no, excuse me. I messed up the helper mnemonic. H is call for help. E is evaluate for episiotomy. We don't do episiotomy, so that's like a surgical incision to make the canal bigger. Not something we're going to do, so you can disregard E. L is lift the legs, so that is knees to shoulders, and that's the McRoberts position. P is apply pressure, so that's suprapubic pressure, so applying pressure just above the pubis, and that's going to help widen that birth canal, hopefully help push that shoulder down and out of the way. If that doesn't work, we can look at repositioning, so helper, there's the R, and that will be putting mom on all fours, putting her on her side, moving mom, whatever's appropriate, whatever you can do. And if that doesn't work, we can try, as an ACP, I can try some rotational maneuvers. So I can put my hand in and rotate the infant. Not something we're gonna do in the PCP scope, but again, it's nice to know that there's an extra step the ACPs can do. So that's shoulder dystocia. So baby's head's coming out and labor stops. Head's kind of, you'll see like a turtlenecking. Baby's head pops out, comes back in. Pops out, comes back in. If you see something like that, it's likely shoulder dystocia. So we're going to call for help. We're going to put mom in the McRoberts position. We're going to apply suprapubic pressure, and then we're going to reposition mom. If that doesn't work, hopefully an ACP is on scene that can do some more advanced maneuvers. The last thing we should talk about is preeclampsia. So preeclampsia is a condition usually caused by hypertension. And we can get some fetal distress, we can start to get some organ dysfunction, and mom's really high, mom can end up developing seizures. So preeclampsia is the cause of, preeclampsia is defined as hypertension around time of pregnancy, typically seen in later pregnancy. Patients who are most prone to preeclampsia would be those after birth. So like 6 weeks after delivery, you can still develop preeclampsia and eclampsia. So preeclampsia is hypertension. Eclampsia is having a seizure or organ dysfunction in the context of preeclampsia. So you've got somebody who's hypertensive in pregnancy and they have a seizure. There's a really good chance that this is an eclamptic seizure. And these guys can get really, really sick quickly. So what we're gonna do, this is mostly from the PCP scope, we're just gonna manage the seizure. So manage the airway, drive them to the hospital. At the ACP level, we might look at Versed or Valium to stop the seizure, or we can also look at magnesium sulfate. It just works on different mechanism and works well for the eclamptic patients, excuse me. So 5 complications we had: postpartum hemorrhage, cord out first, so prolapse cord, one limb presentation, breech delivery, shoulder dystocia, and eclampsia. Hopefully that's clear, guys. I'll have some more detailed videos on this later. Cheers.